welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
Hello, I am Isabel Olivera, a medical writer for EHA. Welcome to today's episode on the reuse of clinical and multiomics data, specifically focusing on rare disease patients. Our guest today is María del Mar Mañu Pereira, an expert in the field of rare anemia disorders. She's here to share her insights on how RADeep registry is changing the way we use patient data to promote research and improve healthcare outcomes. María is also actively involved in the ENROL platform from ERN-EuroBloodNet, which aims to standardize and systematically gather clinical data for reuse in research. Thank you very much for being with us today. So you are involved in all these initiatives to gather, standardize, and reuse clinical data. Why is this important?
Well, we started with this with the RADeep registry in 2016, and why we start with this initiative? Because we realized that it was impossible to have any robust evidence and clinical outcomes that are reliable if we don't pull the data from different countries, because as you said, rare anemias are rare diseases, and then we have a few patients in each country, so we really need to have a European approach and to be able to pull all this data in order to have the minimal numbers to prove a hypothesis or to advance in research.
So what is exactly RADeep?
The RADeep is the acronym for Rare Anemia Disorders, a European epidemiological platform. So it's a registry, for a patient registry, and it is an umbrella for both already existing registries, national registries, but also new registries. The aim of RADeep is to standardize the clinical data and in a way that is aligned with the new developments for rare anemia disorders, and that we can reuse this data for advancing research, both translational research and clinical research. The problem is that it's very difficult if you think about pulling data from different countries. First barrier is language. So in each country we have a different language, but not only this, also the understanding of the definitions for many of the parameters are also different. So we need to understand each other first as physicians, researchers that we are working with this type of disorders, and we need to have a common understanding or what we mean by hemoglobin concentration, something that is simple, but you have different units. You can collect hemoglobin concentration as ranges, or you can have a number. So you need to standardize the way that you are collecting the different information. And then also the second step is to have some interoperability for machines. So it's not only between us, but also we need that all this information can be understood by the computers. So this is the part of the interoperability, and we do this using ontologies and codifications, international codifications. So we are sure that when we pull the data, we are putting together data with the same meaning, and then we can have comparable results.
So how does RADeep compare to ERN-EuroBloodNet?
There are many differences. So for the ENROL is the central registry of the ERN-EuroBloodNet. So this is on the strategy of the European Commission and the member states, and is part of the European reference networks. There are 24 European reference networks. The ERN-EuroBloodNet is on hematology, both oncological and non-oncological, and ENROL is the central registry. The idea of ENROL is not really an exhaustive registry, but is more a platform to promote the interoperability standards and also the FAIR principles. So the first principles is the data needs to be findable, interoperable, accessible, and reusable. And this is what we call the FAIR principles. And in the strategy of the European Commission, the idea is to cope all the fragmentation of data for rare diseases and then work on these principles in order to be able to pull the data, to understand the data, to share the data and reuse it. But ENROL is more on this implementation and promoting all these standards. And also it collects a minimal data, but it's really a minimal data for understanding more epidemiology, but no more than this.
Now to the use of these platforms. How has this systematic gathering of information and standardization of data impacted now research in rare anemia disorders?
Well, I think that we are in the beginning, let's say, because for rare anemia disorders there was really a big need of research and data-driven research. So, for instance, when we started with the RADeep in 2016, there were only 3 registries in Europe for sickle cell disease. The one in Germany, Belgium, and Spain. There were no more registries. There were some databases, but not really registries with a national coverage. What this means that at the end, you cannot prove the hypothesis. You are working always with of course, with your expertise in the clinical settings, but you cannot really prove the hypothesis. We need more data to really prove all these hypotheses or outcomes or how the different drugs work in the patients. So anemias are complex diseases, are chronic. So you have at the end a lot of complications, the disease progression. You need to have reliable information for identifying reliable indicators for the outcomes, for the endpoints. And if you don't have all this, it's very difficult to do any type of research and drug development. So now in the RADeep, we have, for the first time, is the first initiative in Europe for collecting all this data. And we have a standardized clinical data for almost 5,000 patients in Europe from 13 countries. This means that we are supporting the countries for collecting all this data. We established the different expert groups. We were discussing together among all of us what was important for these diseases, what were the priorities, the challenges, and I think it's really very important that we work in this way in a European approach. So, on one hand, we establish a robust basis for all this standardized clinical data collection. And on the other hand, we started reusing all this data with research projects. So we are contributing to 2 EU-funded projects that are Genomed for All and Syntema. And in the 2 projects, what we are aiming is to develop artificial intelligence models for risk scores in sickle cell disease and for vaso-occlusive crisis, for acute chest syndrome, for chronic organ damage. And in Syntema, we aim to develop synthetic data generation. So this is important because there are many unmet needs in research for rare anemias. They have been neglected for many years from health planning. So I think it's the first time that they are really upfront.
Yeah.
Exactly. And I'm very optimistic, and I think that there are more and more clinicians and researchers that are encouraged now with this initiative to pull the data, standardize it, do more research, because for many years we said that personalized medicine was very difficult in sickle cell disease. And it is. It's difficult because it's a very complex disease. But also we realize that the lack of standardized clinical data hamper really a lot this research.
How is AI helping? So you said for developing risk scores? Or
Yes.
And so you mentioned synthetic data.
Yes, there are different aims for synthetic data. One of them is to enlarge the data sets. You can also use synthetic data for imputation. So if you have some missing data in your data set for some patients, you can also predict some of the parameters. So then you have a complete data set for the patients. This is imputation, and then to enlarge the data sets is known as augmentation. So there are different strategies. There is another point that is, as you know, in the European Union, we have the GDPR, that is the General Data Protection Regulation, and also the generation of synthetic data will help for all these barriers that we face for sharing the data across countries. So the way that we are working is also through the development of federated platforms, that then the data of the patient doesn't leave the hospital. So all the nodes are connected to a central node, but the patient's data is not leaving the country. It's not even leaving the hospital. So this is what we are working. The synthetic data also can be used, not now, but if we do properly everything, could be used as an external control arm for clinical trials. This is also a problem, let's say, that for many patients with a rare anemia disorder, they have really very few options for treatment. And then when there is some drug in clinical trials, it's like a bit also from an ethical point of view, having patients in control arms is reducing their possibilities to have a treatment. And then this could be used, the synthetic data, as this external control arm. So you don't need to put patients in a control arm and not receiving the treatment.
Are you already doing this?
We are doing this in one project. I think it's the first time for sickle cell disease. We are doing the models for the generation of the synthetic data, but it's not used for
yet.
No,
because it will have also regulatory
implications.
Of
course. So one step back. So the first thing that we are doing with the RADeep, that we have the real data from the patients. We are now in contact with the EMA, with the European Medicine Agency, and we already had one meeting in Amsterdam with the different coordinators of the different registries, and I was there as coordinator of the RADeep registry. And what the first thing that we want to do is to have our real data sets from the registries qualify for regulatory purposes. So first step, in my opinion, is to have the real data set qualify. Then, if for this, I have to say that all the recommendations from the EMA are really very good for us. So we are in the RADeep, we are developing all our data quality framework based on the recommendations of EMA. And first thing is to have good quality of data, real data. And why? Because also the synthetic data is developed through a model that has been trained in the real data. If the real data is bad quality, the model will be bad quality, and the synthetic data as well. So first point is really to be sure that we have good quality data from the patients. We are doing this in the RADeep, and then in Syntema, We are using a subset of this data set that we already proved all the quality and did all the cleaning of the data. And then we are now about to start with the models for generating the synthetic data. Then once that you generate the model, you need also to do a clinical validation of the data. And for this, we work with the experts, of course. And from a statistical point of view, we are developing the clinical utility frame, also to prove that this data is good enough, the synthetic data.
And you will use this to get also regulatory approval to use this
Yes,
data image.
yes, this is the idea, but step by step. So first you need to start with that this is the idea, yes.
So you have implicated how many countries?
13.
13 countries.
Yes, 12 member states and Norway.
How has been this experience of collaborating with all these different systems, these different cultures, obviously, languages, but these different systems to get all this data gathered?
So it was really very, very difficult to understand or to support our national coordinators for all the legal and ethical part of setting up a registry. So you have to, at the end, you have to learn about many things, about the legal, the GDPR, the agreements, ethics, the informed consent. So the regulation is different from one country to another country. So what is valid in Spain is not valid in France or in Germany. So it's not easy.
Yes. How long has it taken you to set up then this registry?
We started with this idea in 2016. And we started with an ultra-rare disorder with pyruvate kinase deficiency. And then we started with PKD. And for 2-3 years, we were working on setting all the legal, the ethics, also to develop the electronic case report form. So we were mapping all the existing registries, asking for access for the metadata of all the registries, because we wanted to build something that was based on the existing registries, not to start from scratch. But we then realized that actually there were very few registries in place. And then in 2020, we had the 2 years of the pandemic. So this also, when we were about to really, the pandemic also slowed down the development. But I have to say that after the pandemic, now we are in an exponential phase.
Yes.
And we were able to fix all these legal and ethics issues, and also to develop a modern platform and implement all these quality standards. And now the progress is really very good. We have almost 5,000 patients already registered. So this is really very good. And also I want to thank all our contributors, because it's really not easy. This is done out of the clinic's work, also. But I think that now we have a very good expert group and the support of the EMA, of the European Commission. We also collaborate with pharma industry. Patients are involved in the RADeep from the onset. So we have 2 representatives for patients, and one for sickle cell disease and thalassemia, and another one for the ultra-rare disorders. And we would like to have more, but it's also difficult to have patients with enough time to be spent in the registry. But we have them, and they are part of our data access committee, in which we also have 2 legal experts and 1 expert on ethical issues. I think this is very important, to have all these different expertise.
Yes, perspectives.
Yes, and perspectives, exactly.
So now that the data has been standardized Can research teams or people who want to make use of this data access it and use it for their projects, or is it still not ready?
Now we are about to finalize the first RADeep manuscript, and then we will publish everything that we did so far, and also we will include some epidemiological data. And then for next year also we plan to have the second publication on all the data that we have collected. Then once it's published, we can open all this data set for requests from researchers, and perhaps even a bit before. So the answer is yes. So the idea and the vision of the RADeep is to open up the data sets. So we are already reusing this data, as I told you before, with a group of experts in 2 European projects. But then we will open also the data sets to the research and community. Also patients or industry or any legal entity in Europe could request data, not only in Europe, but it's a bit complex. But we have already a policy for data request, and there is a submission form. So you have to complete like all why you are asking for the data, what is your institution, if you have an ethics approvals, and then the data access committee will review the form and then give the green light or some modifications. But of course, first we need to publish the results, and then we open the data sets.
And are you going to be constantly gathering more information?
Yes.
I imagine this is also a lot of organization to
Yes.
keep this running.
Yes, the idea is the RADeep is a prospective longitudinal registry. So the idea is to have a long-term registry that can be upgraded, and it's a modular structure. So we can have different modules for different purposes. And we collect the baseline information from the patients first time when they are registered, and then all the longitudinal data is collected once per year. We have also a standardized procedure to review every year the type of data that we are collecting, if we need to do any change or modification, or for adapting the data that we are collecting to the new developments on drugs or the new knowledge on the disease. And we are funded by public and private resources. So first thing, we have our institutions behind, that all the institutions are supporting the initiative, and this also means a number of human and resources that the institutions put in place for the maintenance of the registry. And also we have these EU calls and funded projects, and we have also agreements with pharma industry. But the RADeep is an academic registry, so all the ownership belongs to the RADeep members. But we have research agreements with pharma as well.
What role is EHA playing or will play in this?
We had a lot of discussions with EHA, and I'm very happy to say that we were officially endorsed by EHA just 1 month ago.
Congratulations.
Yes. We collaborate with EHA also at the level of the ERN-EuroBloodNet, that I am in the coordination of the ERN-EuroBloodNet as scientific director. And we collaborate with EHA for education, for patients' engagement, for guidelines. And this will be another field of collaboration. I think that the role of EHA is really very important to engage the community, to also to discuss the unmet needs of rare anemia disorders, to increase visibility. So we need to start the discussion on how we are going to collaborate in concrete actions. But for sure, I'm confident that will be really very good.
Now there is gene therapy for sickle cell disease and thalassemia. So these patients are cured somehow, or at least have a very long time of remission. But you have to keep track of what's happening to them. So I imagine they are going to be in this registry.
We will have it in our registry. And I think this is also an important point, because the indication for gene therapy are those patients that are suitable for a bone marrow transplantation, but they don't have a donor, a compatible donor.
Yes.
So I think that the RADeep registry will be very important to understand where are the patients and how are the different. What we include in the RADeep registry are also some parameters that are for understand the clinical practice at the national level. Because this is also very important. It's not only the variability of the patient, but also the national health system and how the different care pathways are implemented at the national level. So we will be able to see differences on when the patients are offered with a bone marrow transplant, for instance. It's not, even if it is a standard of care, it is not indicated exactly the same way in all the countries or at the same age.
Yes.
And there are many patients, adults, that they are not screened for a compatible donor, perhaps. So this is the one part that the RADeep registry can contribute a lot for a better understanding on how to find and how to improve access to gene therapy. Then after the gene therapy, there is the European Bone Marrow Transplant Registry, the EBMT, that they are focusing on these innovative therapies. So, of course, we don't want to duplicate what is already in place. And then the idea is to have a discussion with the EBMT and then to see if we have a complementary module for the follow-up of the patients or if they are transferred completely to the EBMT.
This is the same registry where you register CAR-T therapy patients?
Exactly. Yes.
Okay.
Yes.
So it would be all in the same place. At the moment, the ABMT is gathering one registry for all patients that have some kind of genetic engineered therapy.
Exactly.
Okay.
And also the conventional bone marrow transplant. So that's clear that we don't want to duplicate.
Yes.
So, but have some synergies because we have the information of the patient before
Yes.
the gene therapy. So the idea is to have a collaboration with the EBMT.
And mostly you will from the start help to identify which patients could be candidates for gene therapy.
Yes. So this is something that we are working a lot. That is, we are reviewing the RADeep CRF, all the data that we are collecting, in order to be aligned with the inclusion and exclusion criteria of clinical trials. So in this way, we are able to have a European referral system so we can reach the patients. This is also very important for ultra-rare diseases.
Yes. So thank you very much, Dr. Mañu Pereira, for sharing your expertise with us. And thank you to all of you for listening. If you enjoyed this episode, don't forget to subscribe and share it with your friends. And see you at the next episode.
Thank you very much.